Hello and welcome. My name is Gilberto Lopes from the University of Miami, and this is OncoAlert Colloquium 2026. I'm going to be discussing lung cancer early stage, updating you on everything that we saw in 2025. And these are the main findings or the main topics of discussion. We're going to be looking into adjuvant and neoadjuvant chemotherapy and immunotherapy, as well as how we have moved to using targeted agents in this setting. We're also going to be discussing the 10-year follow-up of a trial comparing SBRT to surgery in stage 1 disease. And finally, we're going to be discussing a new test that looks into genomic stratification in early stage lung cancer. So without any further ado, let's start. We have learned from the LACE collaborative group meta-analysis that we could get a small but clear benefit when we gave adjuvant chemotherapy to patients with early stage non-small cell lung cancer. These were cisplatin-based regimens, and usually patients who derived the benefit had tumors bigger than 4 centimeters or had positive lymph nodes. And we also, before the new targeted agent and immunotherapy data, knew that neoadjuvant chemotherapy could give us the same benefit. This is a meta-analysis of 15 randomized clinical trials showing about the same benefit as we saw in the adjuvant setting, or a 5% improvement from 40 to 45% with the use of neoadjuvant chemotherapy. By adding immunotherapy to perioperative setting, we hope that with a primary tumor that is intact, we would have a large burden of endogenous tumor antigens, potentially enhancing tumor-specific T-cell priming and trafficking, leading to more robust activation of the immune system, and hopefully improving surveillance against micrometastatic disease. And that truly has panned out, as we have seen with a number of clinical trials. These are several of the trials that set up this new standard of using chemotherapy and immunotherapy perioperatively, showing that we do get better event-free survival, as well as pathologic complete responses that we did not used to see when we used chemotherapy alone. And indeed, today, as the slide summarizes, we have a number of potential options. In chemotherapy and immunotherapy, we have agents that have been approved, such as nivolumab, pembrolizumab, durvalumab, and we also have now evidence for the perioperative use of osimertinib from the Neoadjuvant study, as well as the adjuvant use of osimertinib from ADAURA, as well as alectinib from ALINA. And we're going to be discussing those in a minute. But first, let's see what we saw new in 2025. And that was the confirmation of overall survival improvement with this approach. In this particular study presented at ASCO and published in the New England Journal of Medicine at the same time, we showed that nivolumab, when added to chemotherapy, not only improved event-free survival, but also led to better overall survival. We see a hazard ratio of 0.72, representing about a 30% improvement in overall survival by the addition of nivolumab in the neoadjuvant setting. This consolidates the knowledge that we already had. And this trial is also interesting because we see here on the upper panel how patients who achieved a complete pathological response actually had such a good prognosis. These are not even curves, they're more like lines. And we see that the vast majority of patients who achieved a path-CR really were alive by 5 years. And these are results such as we had never seen in non-small cell lung cancer. The bottom panel shows something that we're not quite considering standard of care yet, but that many institutions, including ours, do use on a semi-routine basis, which is the use of circulating tumor DNA in the monitoring setting after surgery. And this is definitely something that now we know correlates with survival, and a number of clinical trials are ongoing to try to set this as a new standard as well. One of the interesting questions that date back to 2024, but worth mentioning, is do we need the neoadjuvant and the adjuvant immunotherapy? And this is an analysis of the trials, including nivolumab, which was extremely interesting in the sense that they looked at differences between the perioperatively approach with immunotherapy both before and after surgery, as well as neoadjuvant nivo and chemo for 3 cycles only, which is a regimen that is less costly and can lead to fewer adverse events. And we learned from this meta-analysis that patients that achieved the path-CR really did not get a benefit from continuation of nivolumab. So this is a group of patients that we feel very comfortable offering just the neoadjuvant 3 cycles and then monitoring. One of the findings of the same meta-analysis is that for patients with PD-L1 greater than 1%, we did not see a big difference with the continuation of nivolumab, but this is a group that most colleagues still do not feel comfortable in doing just the 3 cycles of neoadjuvant. And for these patients, depending on how much disease we see during the surgery, we would usually continue for a whole year of adjuvant nivolumab. This brings us to the Neoadjuvant study, which shows the contrast of what we can achieve today in terms of chemoimmunotherapy in patients without targeted mutations versus what we can achieve for patients that have a classic mutation such as EGFR. This is a neoadjuvant study in which patients received osimertinib plus platinum-based chemotherapy, osimertinib monotherapy, or placebo and platinum-based chemotherapy. And we see that chemotherapy alone really did not have the best results. We see just 2% major pathologic response. So note that this is not a path-CR, this is a major pathologic response, but we did see that patients who got osimertinib had about a quarter of the time what is defined as a major pathologic response. Again, these are not path-CR, so the results are not as good as with chemoimmunotherapy in patients without EGFR mutation, ALK translocations, or ROS1 or RET translocations for that matter, but this is certainly something that becomes an option for patients in the neoadjuvant setting if they have classic EGFR mutations. In ALK positive disease, we know that the FDA has approved alectinib, and this is an update we gave you last year, but that's certainly something that has consolidated this year and has become more and more part of our armamentarium. Just reminding everyone, this is the alectinib, the ALINA study in which patients received alectinib or platinum-based chemotherapy, and without a doubt, the patients who received alectinib did better with a disease-free survival improvement that is quite clear with a hazard ratio of 0.24. In summary, this is the first and only so far positive phase 3 trial of an ALK inhibitor in resected stage 1B to 3A non-small cell lung cancer. And this, with the evidence that we have for EGFR mutation as well, confirms that we now need to do genomic testing in the early setting as well, testing for at least EGFR and ALK, but of course it does become more cost effective to do NGS testing from the get-go, and that has become the standard in our institution and in most academic centers in the US at least. These are the guidelines updated for 2026 from the National Comprehensive Cancer Centers Network, NCCN, showing all of the options. Summarizing this, we do have the option of platinum-based chemotherapy and immunotherapy for patients without EGFR mutations or ALK translocations. And again, I would include here that we should not do this for patients with ROS1 or RET gene fusions as well. And for those patients that do have EGFR mutations or ALK translocations, we still don't have true standard in neoadjuvant, but many of us do use the Neoadjuvant data to use chemotherapy and osimertinib in the neoadjuvant setting for patients with EGFR mutations, and some colleagues do use alectinib in the neoadjuvant setting in ALK positive disease, but we really don't have a lot of information in that setting. In the adjuvant setting, without a doubt, we should be using osimertinib for patients with EGFR mutations and alectinib for patients with ALK translocations. One interesting study presented at ASTRO in 2025 is the STARS trial. This was the first to report 10-year clinical outcomes from a prospective comparison of radiation given in a stereotactic manner versus surgical resection for operable non-small cell lung cancer. This was a phase 2 trial, prospective, which was actually compared to matched surgical cohort of 80 patients, and 80 patients received SABR or SBRT. These were given over 3 or 4 sessions, and at 10 years, we saw that with SBRT, we had 69% survival versus 67% survival with surgery, and this is anatomically correct surgery for non-small cell lung cancer, so these are excellent results. And when we look at other endpoints such as lung cancer specific survival, 92% versus 89%, and recurrence-free survival, 57 versus 65, the results were quite similar. I don't believe that this will dissuade us from moving away from a standard of doing surgery for patients with early stage, and these were all patients with stage 1 tumors that were smaller than 3 centimeters, but we will continue using surgery as the standard for patients who are fit. But without a doubt, this makes us even more comfortable to continue using SBRT for patients who are non-operable or who have reasons for which we would like to avoid any surgical procedure. So it's certainly an option. Finally, one of the major advances that has not become a full standard of care yet, but has been used more and more by a number of academic centers in the US, is the use of genomic risk stratification in early stage disease, very similar to what we do with genomic testing in breast cancer today. This is a study called AIM-HIGH, and this was a study of adjuvant chemo for stage 1A and 2A, so early stage non-squamous, non-small cell lung cancer that were identified as molecular high risk. And in this trial, which was a randomized phase 3 prospective study done in 45 centers in France, Germany, and the US, patients with stage 1A or 2A non-squamous non-small cell lung cancer underwent risk stratification with a 14-gene assay. Patients were considered molecular high risk, and this was defined as high risk or intermediate risk scores, were assigned to receive 4 cycles of platinum-based adjuvant chemo or observation. And the results are truly impressive, pretty much more impressive than anything we haven't seen in this setting before. The hazard ratio for recurrence or death was 0.22%. We saw that patients who were high risk and did not receive adjuvant treatment had about a 20% risk of recurrence, again, stage 1 and 2. And patients who did get chemotherapy, that reduced to about 4%. So as I mentioned, this is the most impressive data that we have in this setting, and for many of us in the US, this has become the new standard of care. We do this routinely in our institution, and about half of the colleagues that I have spoken with in the last couple months from academic institutions in the US have started to use this test as well. And it is not yet in guidelines, so you do have to know that, but this is certainly something that we have been doing more and more. And the conclusion from the authors from this study, which we actually agree with, is that the 14-gene assay identified patients with molecular high risk who benefited from adjuvant chemotherapy. And the use of this assay to determine eligibility for adjuvant therapy in stage 1A and 2A non-squamous non-small cell lung cancer clearly has the potential to improve otherwise persistently poor outcomes. I've been participating in clinical trials in this population for more than 20 years, and this is truly the first really positive data that we see. In conclusion, what was practice changing in 2025? We clearly gather more insights on the use of neoadjuvant and adjuvant immunotherapy when added to chemo, and we have seen further evidence of overall survival improvement. Alectinib and osimertinib are now clearly established, and we should be doing genomic testing in early stage lung cancer as well. SBRT has more and more become an option for patients with small stage 1 lung cancer, and Risk Review is the first genomic stratification test to show benefit in early stage lung cancer. If you do have any questions or any comments, these are my emails and my phone number. And again, once more, thank you for being here with us today, and thank you for being in other sessions in the OncoAlert Colloquium 2026. Nice seeing you.